1. Shills. When profit trumps benefit. Healthcare in the United States is ethically compromised. About that there is no debate. The debate is over the degree of compromise and the even more heated question of what to do about it. The Institute of Medicine and nearly every other professional organization in the health arena have chimed in. The areas examined include medical errors, ethnic and racial disparities in provision of care, uneven quality of care, antiquated record-keeping, and administrative inefficiency. They talk about overdiagnosis, overtreatment, and overhead. Each of these areas is surrounded by clouds of obfuscation, a predictable result of all the finger-pointing. Hiding in the clouds is an essence that renders the U.S. healthcare system essentially ethically bankrupt. That essence is conflict of interest. A goodly percentage of the wealth of the country, approaching 20% of the gross domestic product each year, is commandeered by the healthcare system. In Chapter 2, we examine the health expenditures and healthfulness of many countries in the resource-advantaged world. Yet the United States gets the least bang despite expending the most buck. Most of the monies expended in the United States, at least half of this largesse, pass through the system into the pockets of stakeholders without advantaging a single patient. The per capita expenditure of every other resource-advantaged country is half that of the United States, or less, without disadvantaging their patients by even an iota. In the United States, the system and its myriad stakeholders are no longer the infrastructure, they are the raison d'etre. Furthermore, the marketing, lobbying, and pandering is so well funded that entire institutions have been co-opted. Congress tilts toward the status quo thanks to the efforts of legions of lobbyists, as many as 6 per member of Congress. Medical education is now a loss center, barely discernible in academic health centers, which are barely academic and consider healthcare no more than a profit center. Regulatory agencies are often handmaidens of a political agenda or of powerful outside influences. The list goes on and depressingly on. There is a desperate need for a voice on Capitol Hill or in the White House demanding that the healthcare system claim the moral high ground. A demonstrable benefit for patients must trump any demonstrable benefit for any other stakeholder. If an intervention has been studied and can't be shown to offer a meaningful benefit, it does not matter how efficiently or expertly or profitably it is accomplished. It should not be done. Any voice calling for that kind of change will be quickly stifled by those with vested interests in the marginally useful and the useless, unless citizen patients take up the cause. The disclosure dodge in the clinic. Arrangements between individual practitioners and drug or device purveyors are a rich source of conflict of interest. Academic health centers and unaffiliated hospitals are racing to write or expand policy statements on conflicts of interest that relate to the clinical activities of individual practitioners. Several in Congress, Senator Chuck Grassley, Republican, of Iowa, for one, are investigating and legislating. Policy is targeting marketing methods that seem on the surface to be innocuous, the on-site detailing by drug and device representatives, the trinkets and free meals, the samples that cause a physician to become more familiar with prescribing the product than with the product's limitations, the sponsored educational programs that engender comfort with the sales personnel, if not the product, and other tactics. All of these are easy targets for those putting forth policies that treat the collective conscience of my profession. That's overdue. So, too, is a peer review that examines the feigned or real naivete on the part of professionals who claim they are above being influenced in such an obvious way. But physicians owe their patients much more. The fact that policy